it, how to prevent it, and what is the global response. So from the map, you can see that when you combine both clades, I'll compare and contrast the original clade 1 with clade 2, which was the outbreak in 2022 globally, to what's happening right now, primarily in Africa, but also isolated in Sweden and in Thailand. I'll spend a lot of time talking about each of the clades in the historical context, but also comparing and contrasting them. So where did it come from? So Mpox is a DNA envelope virus. And the fact that it has an envelope means that it's pretty hardy. Its most famous relative is the smallpox or variola virus, which is much more deadly with 30% mortality. It's the first disease that we know of for which a vaccine was used, with Edward Jenner taking the lesions from the milkmaids that worked with cows infected with cowpox, and that was very similar to smallpox, so they were protected. And it was the first disease that was eradicated. So cowpox is related to smallpox, and in which the vaccinia virus was derived and used to inoculate people originally against smallpox. But there are lots of different animal poxes like camel pox, horse pox, raccoon pox, skunk pox, and bull pox. But Mpox is thought of as a less deadly smallpox, but very related. So in the 1950s, there were some monkeys in a research institute in Copenhagen, and they were afflicted with an illness that caused this rash. And this was the first time that Mpox was identified. But the first human cases weren't noticed until 1970 in the Democratic Republic of the Congo, formerly Zaire. Interestingly, the number of cases weren't that big, and I'll go into this in some more detail in the next few slides. But a lot of the protection came from concomitant smallpox vaccination that was continued until the early 1980s. Since then, since smallpox vaccination was stopped, there's been an explosion of Mpox of various types in Africa, and in 2022 in more than 100 countries around the world. So you can see that there are different forces happening, ending smallpox vaccination campaigns, increasing human cases of Mpox, which probably was there all along, but kept in check by the smallpox vaccine, and also armed conflict, and that humanitarian crisis. As we know, the intersection between conflict and public health is a really deadly one, and I think that's what we're seeing. In the West, we've seen Mpox sporadically from cases brought from travelers from countries, but it didn't really get into the consciousness of people in the United States, for example, until 2003, when there were animals and animal handlers afflicted and hospitalized. And I'll get into that in a second. So where was Mpox before 2003? It was mainly the original, the OG. It was clade 1A. It was first identified as human disease in the 1970s, as I mentioned, in the Democratic Republic of the Congo. There weren't that many cases reported, even if you account for lack of diagnostics or surveillance. There were 59 cases, but in 10 years, 70 to 80, mainly in people who lived in proximity to rainforests in West and Central Africa. The transmission risk at that point was thought to be exposure to forest animals, not just monkeys, but rodents, squirrels, which probably carry Mpox much more than monkeys do. So the name monkeypox is really a misnomer, a wrong name, because it's not really the reservoir of Mpox. The mortality rate at that point was thought to be around little under 20%, primarily in children under 10 years of age. And following the discontinuation of the smallpox vaccine in 1980, there's been a 20 times increase in cases in the ensuing years. And the risk in In that second wave of Mpox was again thought to be people living close to forested areas, more males than females, probably attesting to who was going and interacting with these animals affected with the virus, and young people. As I mentioned, in 2003, it seeped into the consciousness of people in the US because there was a large outbreak in Wisconsin, 72 cases, no human-to-human transmission, no deaths, all had contact with prairie dogs that were housed next to these Gambian rats that were imported as exotic pets. The prairie dogs are North American. They don't have Mpox, but the Gambian rats did. And the prairie dogs got afflicted with it, and the people who were handling the prairie dogs, the pet owners, also got Mpox at that point. So that was, a pretty seminal event, I think, because it really brought to the point very close to home that when an infection occurs in one part of the world, it can affect all parts of the world. And then in 2022, it really hit the world's consciousness. This was a different clade. So far, I've been talking about clade 1, the original clade, but this was clade 2. And this was been brewing since 2017 because Nigeria had no Mpox cases for about 40 years. And then all of a sudden, in the background, they were having these cases. They were thought to be transmitted sexually or through sexual and intimate contact. So it was a little bit different from people living in the forested areas. It was from here that the Mpox evolved, clade 2, to become even more adept at transmitting from human to human. And in May 2022, there was a global multi-country outbreak, first recognized in Europe and amplified by sexual networks, primarily amongst men who have sex with men all over the world, where you see these orange dots. And in July 23rd, 2023, the WHO declared a public health emergency of international concern. We've had about 7 so far in the last 9 years, so they've been coming fast and furious. In the 2022 global outbreak, there have been about 100,000 cases in 122 countries. Most of the countries, more than 100, have never seen Mpox transmitted locally before, so this was a very, very significant event. There were only 207 deaths, about 0.2%. And the risk, like I mentioned, was amongst gay and bisexual men, although there were some women who got Mpox in the 2022 outbreak and also some children, but not many. And then where are we now? So in 2024, we have the re-emergence of clade 1A and a new clade 1B that I'll talk about. So since January of 2023, so again, what you see is this constant theme of something actually happening long before the world paid attention. And it's been going on and it's just getting worse and worse. And only at some breaking point do people start to pay attention. So since January 2023, the Democratic Republic of Congo reported more than 27,000 cases and more than 1,000 deaths, mainly in clade 1. And like I mentioned, this is exacerbated by civil conflict and refugee camps, population displacement, no school for kids, removed from that protective, environment of schools. And in this situation, we have children under 15 accounting for 70% of the cases and more than 80% of the deaths. And on August 14th, 2024, the WHO declares a public health emergency of international concern. Again, the second time for Mpox after 2022. As you know, there are several countries in Africa now with Mpox, with clade 1, including previous countries that had never seen it before, like Burundi, Rwanda, and Uganda. And now there's been at least one case in Sweden, one case in Thailand, derived from people from these areas who had traveled to these areas and going back to these countries. The epidemiology and transmission is mainly rural still, but there's been a new sort of offshoot of clade 1 called clade 1B, which kind of acts more like clade 2, which we saw in 2022. So in this Democratic Republic of Congo mining town, there was an outbreak identified where 52% of the cases were female, 29% were sex workers, and in genetic analyses, this looks very different from clade 1, but still related and not clade 2. So it's kind of an offshoot of clade 1. But really, when you look and compare them, it's like a little bit of clade 1 and a little bit of clade 2. Clade 1 in terms of affecting men, women, some children, but clade 2 like in terms of that sex role or intimate contact epidemiology. So who's getting it? Again, it's different depending on what clade you're looking at. So like I mentioned, the original clade, clade 1, now called clade 1A, it's mainly children with a high mortality rate. Clade 1B, the outbreak in the mining town in Congo, is mainly amongst heterosexual women and men. And there's been an unclear role, but still emerging, of non-sexual contact transmissions. So what's the role of surfaces and bedding and face-to-face contact? I think that all needs to be worked out more. And then clade 2 that we saw in more than 100 countries in 2022, primarily affecting men and trans people who have sex with men, about 98 to 99% of the cases, and amplified by gay saunas and networks in which people traveled. So how do patients present? Regardless of the clade, most incubation is about 7 days after exposure, but a high range of when people develop disease after exposure, excuse me, up to 21 days. Most people have first flu-like symptoms, more in clade 1, the original. So with fatigue, fever, lymph node swelling, muscle aches, and sore throat. This can be fairly non-specific, but the rash is very specific, and that happens in pretty much all cases. 100% of people develop this rash a few days after the flu-like symptoms. And in clade 1, the original, it mainly affects the face and the arms and the extremities, and then other parts of the body. In clade 2, the outbreak globally in 2022, it mainly affected the genital area, really, attesting to the site of exposure or the site of inoculation. And then it spread to the face, arms, and trunk. We know more about the 2022 outbreak because that has been extensively studied. And about 10% of these people hospitalized, mainly for pain and superimposed infection with bacteria on top of the lesions. And about 25% of the people attesting to the way in which this Mpox clade 2 was transmitted also had another sexually transmitted infection. So the rash, 100% of people generally get the rash. It follows the flu-like symptoms. People might think it's herpes or syphilis or folliculitis or abscess. But the movement of the rash is key when it's subtle. If it starts off in the genital area, it generally moves to the face and the arms. The rash can have a little dimple in the middle or umbilicated. It's generally very painful and can also affect the palms and soles, like syphilis or Rocky Mountain spotted fever. Eventually, the rash crosses over, scabs, and falls off, and then people may report itching. But it's really a lot of pain and then some itching as the rash evolves. The whole process takes about 3 weeks, which is very different from many other infectious diseases where somebody's feeling better in 5 days, or like COVID. But this is like, you're in for 3 weeks. You're taken out of the workforce. You're taken out of school. So it's quite significant in terms of its impact on quality of life and earning potential. What we learned about clade 2 and Mpox in children, like I mentioned, it wasn't that many kids who got it, but the clinical presentation was generally similar to adults, but mainly rash in the trunk. In kids who are under 12 years old, and in adolescents, they act pretty much like adults in terms of having more of a genital rash, preceded by the flu-like symptoms. None of the kids under 12 years old had a rash in the genital area. Again, leading us to believe that it's really where you get the contact is where you get the first rash. For kids, this might look like chickenpox, zoster, herpes, hand, foot, and mouth disease, molluscum, drug eruption, allergic reactions, syphilis, and scabies. So it's really important to have a keen sense of awareness of how this rash evolves. So putting all the three different clades together now, you can see that they're a little bit different from each other, but also similar. So in terms of the incubation period, the original Mpox, generally a longer incubation period. Clade 2, the one we saw globally in 2022, shorter in general, about 7 days. Systemic symptoms, much more common in Clade 1, with fever in about up to 90% of people. Fever in a lower proportion of people with Clade 2, as low as 50%. But the rash is much more dramatic in the original Clade 1, with about a third of patients with up to 1,000 lesions, mostly the face and extremities, and then moving to other body parts. Clade 2, mainly in the anogenital, oral, and perioral area, depending on the exposure, usually through sexual contact, and fewer lesions, about 1 to 20. And then Clade 1b, that sort of evolution of Clade 1a, in the Congo mining town, they looked a little bit more like Clade 2 with more genital lesions. Again, attesting the fact that the virus has evolved or mutated to exploit other ways of transmission, which is through sexual contact and sexual networks. Risk factors for severe disease, like I mentioned, for the original, it's children, but also pregnant persons. In Clade 2, it's people who did poorly back in 2022, were people who had uncontrolled HIV and AIDS or who were very immune compromised, like transplant recipients. Mortality, 5% in adults with Clade 1, about 10%, and up to 20% in the original outbreaks in children under 5, and less than 1% in Clade 2. So the mortality is a little bit hard to figure out, because is it because it's affecting a lot of children in rural areas who have other diseases as well, like measles, which is also experiencing a resurgence in conflict? Or is it due to a lack of access to hospitals in these rural areas? But most people agree that Clade 2 is a more benign course in terms of mortality, but it certainly causes a lot of morbidity. And like I mentioned, you're taken out of the workforce or schooling for what, 3 weeks. Asymptomatic infection is being followed very closely. It's thought to happen, but it's still at this point thought to be rare in both cases. So how do you diagnose it? You diagnose it by a PCR. So a lot of the difficulty in surveillance in Congo and other countries is really lack of diagnostic test kits. It's a lot of it is just visualization, and then you clinically suspect it. And then, if you have access to PCR, that's the way to diagnose it. As a result of previous outbreaks, we generally would recommend a mask, gloves, eye protection when interacting with patients with Mpox. And at least in the US and other places, it's been liberalized in terms of who can do testing to also include commercial and academic labs to reduce barriers for having people diagnosed. How do you treat it? Well, a lot of times you treat it by controlling the pain, but there is a drug that I'll talk about called tecovirimat or Mpox, and there are other drugs that can be used, particularly in eye disease like cidofovir, brincidofovir. Immune globulins have also been thought of, and sometimes a vaccine could actually be used for treatment because the incubation period could be long, up to 21 days, like I mentioned. If you get the vaccine early, after you've actually started getting symptoms, because the incubation period is so long, or after exposure to a known case, you may attenuate or make the disease course milder. So let's talk a little bit about tecovirimat or Mpox. It's an antiviral. It's available both as an oral form and intravenous form. It was developed as a bioterrorism drug for smallpox in 2018, and FDA approved then. 3 pills twice a day for 2 weeks. In the United States, and in other parts of the world, it's given through investigational drug use. There's a big study now through the NIH called the STOMP study, the study of tecovirimat for Mpox. That's the primary way you can get drugs, and it's also available under expanded access IND from the CDC. In Europe, it's approved, so you don't need to go through all of this informed consent to get it. But global equity remains a big issue. So when we were seeing it back in 2022, this is one of my patients that I presented before. You can see that it was very, very extensive. His palms, his soles, his face is very visible. It was very emotionally distressing to him. He got Mpox, and then by day 3, it really resolved very quickly. So we had these criteria as to who would benefit from it. Either you had considering disease, like you were hospitalized, but it was in a precarious position, like in the rectal area, oral ulcers, or eye involvement, or you had an immune-compromised host, pregnant or breastfeeding person, or somebody who has bowel disease, or bad dermatologic disease like atopic dermatitis. So I'll just read one quote from one of my patients. I feel night and day to what I was experiencing this weekend. Actually, since the day after my UCSF visit, I didn't need to take any painkillers, even to sleep. Prior to that, I had trouble sleeping even more than an hour at a time. New lesions have stopped appearing, and all the ones on my body and face seem to be healing and peeling. Yesterday was still difficult to walk, but today I can walk at a semi-normal pace. My hands and toes just feel numb, but I assume that's due to the coat of dead skin on them. I'll read the second one too. I fear especially how this will impact the most vulnerable amongst our community. I'm a highly privileged remote worker, high earner, ample paid time off, with a partner who can care for me and no dependents. I was completely debilitated, but got through okay. I can't fathom the damage Mpox can do to a gig worker or a single parent. So there was some disappointing news in the last few weeks, which was a study in the Democratic Republic of Congo, co-sponsored by the NIH, a randomized controlled trial where we had the beginning results, but not a lot of detail yet, where patients had to be hospitalized to be enrolled in the study. They could be at any stage of Mpox, and there was no difference in the people who got the drug or the people who didn't get the drug. But the mortality was much lower than the mortality that was expected, which is about 5% in the community. When they were hospitalized to get access to the drug or placebo, the mortality rate was 1.7%. So it really shows that just getting supportive care probably has a big impact on the mortality rate, which makes a lot of sense. So why didn't this work? I think people are still trying to understand. Is it because it's clade 1 and not clade 2? I really think it's because this was a diverse group of patients with different times since the onset of disease. And we know from COVID, for example, with Paxlovid or even remdesivir, it only works best a few days after you get diagnosed. So the longer you take it, probably the harder it is or the less likely it is to work. In fact, in previous animal studies, animals treated within 4 to 5 days showed the best outcomes. And after day 7 or so, they started doing much more poorly. So there are ongoing studies in clade 2 right now, like I had mentioned. Although people have been using it, they've been also using it in Europe. So how do you prevent it? Well, the main vaccine is Jynneos, which is made by one company in Denmark called Bavarian Nordic. That's the main vaccine we use in the United States. It's not a live sort of vaccine that we worry about. It's replication incompetent, safe for everyone, even immunocompromised individuals. It's FDA approved. It's now on the routine vaccination schedule, mainly for men who have sex with men right now in the United States. 2 doses, 28 days apart. efficacy of 2 doses up to 90%, efficacy of 1 dose as low as 36%. And what we did in the beginning was stretch the supply by 5, multiplying it by 5, by giving it subcutaneously instead of intradermally, so more surface. And you can spread the number of vaccines you can use using that method. This hasn't been talked about in this particular outbreak in Africa, but I also personally wonder if that could also be another strategy. So this is people lining up. I remember in 2022 to get vaccines. It was really, really in high demand because the disease was just so prominent and so scary to a lot of people. It wasn't scary in terms of mortality rate, but it was scary in terms of the visual, representation of disease, like Kaposi sarcoma and HIV. Somebody with Mpox could be walking around in the street and they have it. It also was very stigmatized, and people were not drawing blood because they thought people had Mpox, and they were taking pictures of people in trains and public transit and putting it on social media, even though they didn't have Mpox, to say that this person had Mpox. How does it spread? I think this information about 1B is evolving, but it's really contact is the most efficient way of spreading it, skin to skin. And that's why sexual networks is such a potent way of getting and transmitting Mpox. Bodily fluids, it's been isolated in bodily fluids as well. But I think the role of household contact through fomites like fabrics, towels, bedding, and other surfaces is probably playing a role in Democratic Republic of Congo, where so many kids are getting it and so many of them are dying. Because it's probably more than just intense skin-to-skin contact. So something has to be going on here. Very little in terms of droplets and very low risk of everyday exposure in public. So right now it's thought to be a very low risk in the United States for clade 1, 1A, and 1B. But certainly we have still several hundred and more than 1,000 regular clade 2 cases left over from 2022. That's become endemic in the background. So what about a global response? I like the quote, an infection anywhere is potentially an infection everywhere. So again, more than 7 public health emergencies of international concern now. We have to stop thinking about an infection elsewhere is out of sight, out of mind, and really work together because it can really rapidly spread very easily. During COVID, when we had a lot of COVID and incarcerated people and people who were in prison, many of us advocated for vaccination and safe practices and PPE in prisons for incarcerated people because people apart from the humanitarian issues around the prisons themselves, people going in and out of the regular community into the prison system is one thing. And also people who get sick in the prison system affects our whole health system. So we have to stop thinking about us and them and thinking about all of us together, which I think in this audience is like not a crazy concept, but you'd be surprised how many people think about this in the highest levels. I think diagnostics are really a barrier in terms of leading us to know what the extent of the problem is. And those tens of thousands of cases are probably just the tip of the iceberg, mainly because people are not being diagnosed as well, and that leads to surveillance, and then knowing how we're doing with our intervention. It's estimated about 10 million doses are needed right now to put the epidemic or to nip it in the bud. But the pledges by the US, Germany, France, Spain, and Pharma Bavarian Nordic, as well as a Japanese company called KM Biologics in Japan, are not enough. I think the highest number was probably 250,000 from Spain, from their own stores. But again, it's moving very, very slowly. And the more you wait, the more transmission occurs, the more it's leaving the borders and affecting many other places. I think drugs are well, another barrier about vaccines is, of course, the WHO process for approving the vaccine, which is very, very slow. In fact, they still haven't approved the Mpox vaccines, even though it's been approved in many places around the world and by different governments. So what they've done as a response recently is to give the ability and the power to Gavi and to UNICEF to try to get the vaccines on WHO's behalf in order to accelerate the distribution of vaccines to the afflicted countries in Africa. Drugs are a barrier. Of course, they're very much in short supply. And again, I mentioned the disappointing results from the initial reports from the response of tecoviriman and clade-1. Although, again, I wonder if you had a study that looked at more early treatment, if it will be more beneficial. And again, with clade-2, at least in my patients, I saw a very, very dramatic benefit from using the drug. And of course, we are coming off a pandemic of COVID. There's a lot of misinformation, disinformation. There's a lot of us versus them. There's lack of investment in public health. We're a treatment-oriented society in the United States. You only invest in something when you see it around you instead of preventing something. And so that leads us to where we are in the future. So, is it going to be a self-limited outbreak? I think not. It's going to be around with us now in different varieties and different clades. It's going to continue to affect more and more subgroups. It's already become endemic. Even from 2022, that Mpox in many countries around the world, clade-2, has not gone away. It's probably in the wastewater system, it's in the animal population, it's in the human population. And what we're continuing to see is these recurrent large epidemics. So what can we do? Well, I think right now, at least in the West, we have vaccines available. So vaccinating as many people eligible as possible, but really trying to get vaccines to the places that need it the most is really going to be key. We have to deal with stigma. Again, Mpox is very visible, and we saw that in 2022. A lot of people were highly stigmatized with Mpox, and I can imagine that will happen all over the world as well. In this story here on the right, this is one of the stories I mentioned where people had filmed this young woman who had another skin disease or manifestation. It was neurofibromatosis, and they put her on TikTok and called her out for having Mpox. So how do you squash an outbreak? Well, you align science and politics. It's easier said than done. In the United States, that hasn't really happened. You have to have a national strategy. It's really more difficult when you have multiple countries with outbreaks happening at the same time, because although the WHO has a lot of influence, it doesn't have a lot of policing power, just like the CDC isn't an enforcing group. It's just really a group that influences. Communication is going to be key. How do you straddle the balance between not making people panic too much and giving them enough information so that they advocate for the countries that need it the most and are aware so that if it happens in the community, people can know how to identify it and get people medical attention when they need it. And of course, cooperate globally. So let's see here. So I think in terms of the questions we asked at the beginning, where did it come from? Who's getting it? How do patients present? How to diagnose it, how to treat it, how to prevent it, and what's the global response? I think the take-home points are, it's been around for decades, since the 1950s, humans first time in 1970, endemic in Africa, now I think endemic around the world with clade-2. The 2022 global outbreak primarily affected queer men or men of sex with men. The 2024 Africa outbreak predominantly in children, but also you can see that there's been a little bit more heterosexual transmission now with clade 1B. Patients present with flu-like symptoms first, about 7 days after exposure. Lymph nodes are a big feature as well, and 100% of people generally develop this rash. You can diagnose it with molecular methods like PCR. It generally resolves on its own, but it takes a while, like 3 weeks. And at least we know we can treat clade 2, sorry, that should be with tecovirimat. You can prevent it with vaccines, and we need to act now because it's likely already endemic outside of Africa, and we need to continue to have vigilance. So during the Mpox outbreak, I and a bunch of others worked really well with media and to really try to communicate what was going on and not to have people panic, but to have them get vaccines, etc. And I think we were genuinely successful as a country, as a world in highlighting how people got it. People had changed their sexual activity because of this information. They got vaccines because of it. And it went from almost 100,000 cases to just a few hundred this year, at least globally. So this is Reggie Aki, who's an anchor for ABC, and he's really speaking about how we can all be activists with these outbreaks, particularly around Mpox.
Thanks so much, Reggie. I had actually another follow-up question, which is, how do you use media for activism, and how can clinicians and physicians get involved in that?
Well, I think it's especially important that we have people on our air and online who are part of the communities that are affected. So, for COVID, we were all affected. There wasn't anyone that COVID didn't touch. And so that was a little bit easier. But for something like Mpox, specifically in San Francisco, where we have such a large queer population, and where at the beginning, we weren't getting a lot of information about Mpox. And that's where the trouble really starts, because that's when there's misinformation, and that's when there are rumors being spread, and that's when panic can happen. So I really saw that as an opportunity to try and prevent the panic and try and get people the help they need as fast as possible. And to be quite honest, to play a role that sometimes our positions are allowed to play, where we could push major entities involved, including health departments, including our hospitals, and including our politicians, to do something in the absence of action. And what we were seeing from our point of view was not a lot of alarms going off when we thought that there was an urgency. So we play a part in that, but we also have to reach out to physicians in our community who know the players and are also a part of that community, which again, Dr. Peter Chin Hong stepping up after exhausting him with COVID and then immediately going into Mpox, having him and others like him, but especially him, involved in a conversation that he is on the front lines of and also a part of that community, invaluable.
And congrats on your GLAAD award, Reggie. So your efforts can be underestimated. We are also proud. So thank you.
Thank you. And, we did a segment on our air with Dr. Peter Chin Hong and a man named Will in New York who had Mpox as we were speaking with him. And the bravery that Will Hutchinson showed us in that piece was really remarkable. So to have someone who knew what it was like in the moment to treat people with Mpox and knew someone else who knew what it was like to have it, and to just let them have a conversation and have me moderate it occasionally was so powerful. And the fact that GLAAD recognized it was truly an honor, an unexpected one, but one that I don't take lightly. And all credit goes to Dr. Peter Chin Hong and Will for participating.
Thanks so much, Reggie.
Of course, thank you.
Thanks.
So this is me just reflecting on Mpox. I happened to go to a conference in Switzerland, so I made a pilgrimage to Geneva just to stand in front of the UN office. It was closed on Saturday, but really looking at all the people who came to the UN building to have from all over the world to really take their pictures in front of it was really, I think, eye-opening and inspiring to me because it really showed that, we are one world and UN and the WHO still have a big symbolic role to play, even though they don't have a lot of enforcing capabilities. So I think that's it for now, and I'm happy to take any questions.
So thank you so much, Dr. Chin Hong. That was fantastic and very timely and a very important topic for us all to hear about. We're going to transition now to a Q&A section. I believe we'll start with our colleagues at the Mbingo classroom in Cameroon, and then we'll take a few moments to get into our questions posted in the chat.
Elliot, maybe we can start with the Q&A until we have colleagues from Bingo who come
Sure.
on.
Of course. So we have a couple of questions in our chat. Our first one, I think, is asking about the association of Mpox with patients with RVI. Maybe that represents respiratory viral infection.
Yeah, I mean, I think that's one of the sort of co-infection with other viruses is one of the hypotheses as to why people might do more poorly. In terms of RVIs, it's not really clear. We do know that a lot of RVIs like influenza increases the sort of outcome with other infections you get after. It kind of changes the immune environment. Also COVID too. So it makes sense to me that if you have two, it's much better than 1+1. And again, that's thought to be one of the reasons why mortality is higher in some areas if you have more than one infection with viruses.
Excellent. Thank you for that. We have another question. They would like to know what the major cause of death is for patients who are affected with Mpox and what systemic complications does it carry?
Yeah, so it is like typically uncontrolled skin infections with bacteria like staph. So that's one, and just like whole body infection and sepsis because it gets in the bloodstream. So that's the first thing. The second is when you have Mpox affecting the mouth and other areas where you have bodily function, particularly the mouth, it affects nutrition. And that's thought to be one of the main drivers of infant mortality and childhood mortality. It's just like you can't get enough food to eat. So because it's so painful. So that's probably the primary reason in Africa right now, and even in US with HIV, uncontrolled HIV. There are other places that Mpox, I didn't mention it, but you can also get brain infection, eye infection, and when you get it in those places, it's generally a higher mortality as well. But the vast majority of people have regular Mpox, and again, if it affects the mouth, you can't eat, and that's the main way people die.
I have another question. They would like to know if the disease stage matters in terms of the response to the treatment, and some other questions, including should we treat with TPOXX if it is available for all those who are immunosuppressed, regardless of disease severity?
Yes, I mean, I feel like we should. And again, the mortality is generally so high in those populations that it doesn't harm you. And in my experience, it helps. And we know with pretty much every antiviral we use, HIV, for example, the earlier you use it, the better it is. So to me, it's kind of a no-brainer in something that doesn't cause a lot of harm. And the mortality is higher in some populations that I would use it if I had access to it.
And to follow up to the same author of those questions, what are some common complications that practitioners should anticipate for those who have been administered TPOXX? And are there any sequelae following Mpox infection, especially those who have been untreated?
Yeah, so for the medication, it's really well tolerated. I haven't had a patient who couldn't tolerate it. It has some mild stomach upset. That's probably the main thing, but generally it's so easy to take. And people are motivated to take it because they're seeing all this stuff. They feel really uncomfortable. Some of my patients cried every time they look at themselves in the mirror. So not many. And in terms of long-term consequences of Mpox, none that we haven't studied it that well. But none that are thought of in terms of other infections you get after the fact, apart from the bacterial infections we talk about, but after recovery, we don't think so far that you get that's the risk of getting anything else. We do know that when you do get infected and recovered, that pretty much, we believe, gives you lifelong immunity, as opposed to vaccine. We're not sure how long that immunity will last.
And is there any data regarding transmission of Mpox for those who are pregnant from mother to fetus? And also, do we have any safety data for TPOXX in those who are pregnant?
That's a good question. I'll have to look that up. I can't remember off the top of my head. There is an association of Mpox in pregnant people with fetal loss, miscarriage, and because pregnant persons are relatively immunocompromised, just like with COVID, there's thought, again, not as much data, but thought to be a higher mortality rate in pregnant people. So both risks for the mom or the pregnant person, as well as the unborn child.
Thank you so much. I believe that these are all of the questions that we have written in our chat. If there are any questions from our MBingo colleagues, we can open up the floor
Yes.
to you all.
Yes, Dr. Elliot, Dr. Peter. Yes, we are so happy to, and we feel privileged basically to have Dr. Peter again. Our first interaction was actually 4 years ago, so when we had a discussion where you truly demystified COVID for us. So that was quite interesting, and we were quite excited to come here today again and learn from you. And it's just been as impressive as the first session. And we do have a couple of questions from the group, so I'm just going to invite the various physicians with their questions to come in and ask their questions.
Thank you so much. That warms my heart. And I hope I can visit you sometime in person.
Yes, Dr. Kinetoki. Yes, I just want to have more clarification about the vaccination, because apparently now we are using the one that was used for smallpox, and I want to know if there's really a specific for Mpox that is developed now, and what are the difficulties? Maybe we are not yet sure about the rate of prevention because we don't have a lot of population. What should we expect maybe in the next 10 or 20 or 30 years? Because we feel like it could be the solution for what is coming.
Yes,
Thank
those are
you.
great questions. Right now, there is smallpox vaccine available. It's WHO approved, so it doesn't have to go through a WHO approval process. But it's it's risky for people who have a compromised immune system, and the Jynneos, the specific smallpox Mpox vaccine, is thought to be a lot safer, and that's why people are trying to get that for the countries with Mpox rather than giving the old smallpox vaccine. And again, in the US, that one company from Denmark, Bavarian Nordic, is the only manufacturer around the world. But for Africa, another company from Japan is also going to probably provide a very similar vaccines to Gavi and UNICEF. And that name of that company is, I wrote it down, KM Biologics. So there's less experience with the Mpox specific vaccine because it wasn't really used a lot until 2022. So there are a lot of questions like, how long will the immunity last? We do know that for some people who got 2 shots, that it didn't prevent them from getting infected after a year, but just like the COVID vaccine, it prevented them from getting serious illness, and it was a much more rapid course. It wasn't like the whole 3 weeks. So personally, I think for safety reasons and for what we know about efficacy so far, that the Mpox specific vaccine is the way to go. I think ways that we multiply the vaccine, like I mentioned, which hasn't been talked about yet, is giving it just really under the skin subcutaneously instead of intradermally, because because there are more immune cells there. So you just need 1/5 of the dose to get the same impact. And that's what was done early on when we didn't have enough vaccines. So that's one thing. I think, yeah, so those are some of the issues with vaccines. The other issue, of course, is cost. Right now, because it's only, I wish it would go generic, or like some other company can make the vaccine, because when you have just one company or 2 companies making it, the cost is really prohibitive. And I think the estimate is like the cheapest is like $100 a dose. You need 2 doses. So it's not sustainable to have like a little bit here, a little bit there. And the best solution will be infrastructure in Africa itself to produce vaccines for the continent, instead of like relying on these different powers to provide vaccines in a very piecemeal basis.
Thank you so much, Dr. Peter. And I believe you answered the other question that we had already. It was about immunity post-infection, and you already provided some clues about that. So thank you really very much. And this is so relevant right now. We've had more than 50 cases already in our country. And definitely things like Mpox are, not going to be available. So it's good to understand all these, know the precautions that we can take, and just be well equipped to face what is definitely coming to us. So thank you very much.
And I think well equipped to communicate about it and advocate about it in a very knowledgeable way, knowing all the issues, so that I think all of us can play a big role in influencing others, because clinicians have a big part in influencing politicians. We learned that during COVID, even during a little bit of Mpox when it went around the world in 2022. We're learning that about what's happening with polio right now in Gaza. We're learning that about avian flu. So, there's a big role that we can all play in having a ceasefire, or reducing the negative impact of conflict on diseases.
Thank you, Peter. I had a question for you too. So first of all, an excellent presentation, like always. You're such a great speaker, and this was very educational. As far as preventing spread in children, I wonder how we can do that. In different parts of the world, in daycares where kids are exchanging, licked products and things like that. It's very hard to keep it, prevent transmission of any infection. So I was wondering if there are any strategies to prevent spread in children, given the high mortality, which was reported, as you mentioned, in DRC.
I think the ideal strategies are root cause interventions. So like vaccines, or not having conflict, not having kids in school, and not having nutrition during what's happening in DRC with the rebel forces. But apart from that, what we know is probably like inoculum effect, at least with clade 2 and other clade 1s. Like there have been transmission cases, but they're not easy. So that's why they're clustered in households, like changing the bedding sheet with people with scabs that are on the bed, inhaling those scabs. So I think the simple act of quarantining will probably go a long way, not sharing utensils. But probably the biggest contact is scabs on the bed sheet, and you changing them, sweeping them up the surfaces, and then inhaling it. but we don't really understand a lot about this new, how it's mutating. So we need to continue to be vigilant about new ways. But yeah, so I think all of these are cosmetic solutions, like the things, but we really have to advocate for the root cause solutions.
That's a great answer. Thank you. And I think there are a few more questions in the Q&A box. We can wrap it up fast. From Dr. Khada Chana, thank you for your nice presentation. What is the death rate of monkeypox?
So death rate is less than 1% of clade 2 when it went around the world in 2022. About 5% overall in the clade 1. But once you get to under 15 and under 5, it goes up to like 10% and higher. So in big picture, less than 1% clade 2 in globally. The current clade 1, 5 to 10% or higher. Higher, the younger you are.
All right, thank you. And then we have Dr. Kedo Tukeni. A warm welcome to Dr. Kedo Tukeni from Jema in Ethiopia. And the question is there any way that the medicine, TPOXX, and vaccines can be distributed for those at high risk in Africa? Any way we can proactively try to collaborate? Can Health for the World play that role? I can answer from perspective of Health for the World. We are continuously working on humanitarian aid arm of our organization, so we will be working on that for sure. And there are other international humanitarian organizations which are working in this field, and I think they are, especially Gavi, which is the Vaccine Alliance, which is distributing vaccines around the world. They are specifically targeting the vaccine shortage in the low and middle income countries, and an excellent organization too. And thank you again, Dr. Tukeni, for joining with your team from Ethiopia. And then there's a question from Dr. Kathleen McKenna. Should healthcare workers volunteering in rural Tanzania get vaccinated?
100%. If it's available, there have been several healthcare worker transmissions from patients. And that's, to me, it's kind of a no-brainer in a place where you're getting a lot of exposure. And you probably would need fewer vaccines, at least than to initially, or it should be one of the priority populations.
Okay, excellent. So I think those are the questions. And before we close, Dr. Elliot Winford did a great job moderating, and Dr. Peter Chin Hong, an excellent presentation. Just speaking about the humanitarian aid of our organization, we are helping out Bingo Baptist Hospital in Cameroon, who you can see here, in the need for incubators in their neonatal unit. And if anybody's interested in supporting the incubator needs, here is the link. I'm sorry, you can hear my child in the background. Anyways, but Dr. Shinda, if you're there, if you can just speak for 1 minute about the need at the hospital. Okay, so I can just talk a little bit until Dr. Shinda comes. Currently, straw baskets are being used for helping babies after they are born, preterm babies, and there's a need for incubators with phototherapy unit. So we are fundraising for this right now to help the babies in Bingo, Cameroon. The doctors here are very dedicated. We have been working with them for a long time, and so if anybody's interested in supporting this, that would be the link. All right. Dr. Shinda, do you want to speak? Yeah.
Yes, I am. Do you mind allowing me to share? I'll take 2 minutes instead of 1 because I think our babies deserve it, if you permit me.
Absolutely, we can do it. So let's see. Here, can you try sharing now? And Elliot, if you can unshare, maybe Dr. Shinda can try sharing.
Yes, I can. Thank you.
All right. Perfect. We can see the screen, Dr. Shinda.
Thank you very much. So I'll just go right through it. It is basically, a fundraiser for Cameroon, and thank you once again for Health for the World for helping us with this. So my name is Chinda, and I'm one of the physicians here in Bingo, and I would like you to meet Baby Marvelous. She was admitted in the hospital for low birth weight after a very short-lived pregnancy of 28 weeks. She's presently here benefiting from the comfort of the only functional incubator that we have in Bingo right now. But very soon, we will get sicker, smaller, more demanding babies. And when this happens, we will have to move baby marvelous to a basket. And not because we want to, but because we do not have a choice. There are just not enough incubators available. And this leads to poor temperature control. This leads to a higher likelihood of infection. Now, unfortunately, this is not just the story of baby marvelous. Several babies really go through the same. And whether we want it or not, this results in worse outcomes and a higher mortality. We are in Bingo Baptist Hospital in the northwest region of Cameroon. And as you probably know already, this is one of the regions struck by the crisis, by real socio-political unrest. Despite this, we have a dynamic team of physicians that try their best to provide care to all the patients that come to us. And one of those cares that we really endeavor to provide is neonatal care to the really sick and demanding babies that come to us. But this care we provide is unfortunately really limited by lack of equipment. Because there are only few incubators, occasionally we have to nurse 2 babies in a single incubator. Or as you noticed already, put babies in small baskets. Or even to give their IV infusions, we have to use burettes or even count the drops manually. So basically what we are doing today is calling on you because you can make a difference. So we would like you to join Health for the World as they attempt to support us in our endeavors to put a smile on mothers and babies' faces. And thank you for your consideration. And please remember that even the smallest contribution can make a great difference and save babies' lives. Thank you.
Thank you, Dr. Shinda. That was a very important message, and thank you. And you did a very good job presenting it. Really, really, really appreciate it. All right, I think that should be all. Peter, heartfelt thanks again for such a wonderful talk at such an important time. We really appreciate it. Our global audience is also, I'm seeing the thank you messages for preparing us for this global health emergency. And thank you everyone for joining. And thank you, Elliot, for doing such a great job moderating. Really appreciate it. Have a good day, everyone. Thank you.
Thank
Thank
you.
you.
Bye.